The sun is barely up when Earl's truck rumbles down the quiet road. Peggy sits in the passenger seat with a folded sheet of paper in her hand. And Rôvi sits in the back wrapped in her flowing cloak, sequins catching the early light like tiny stars. Earl glances over at Peggy. "Hey, Peg, tell me the address of this next yard sale. It's that estate sale, right?" Peggy unfolds her paper. "Oh yes, it's over on Paradise Hill, starts at 7 a.m. Earl nods, satisfied. "Oh, that's perfect timing. We got plenty of time before the seminar." Peggy smiles, already excited. "I can't wait to see what they have. These youngsters don't know the value of their parents or loved ones' cherished treasures." Earl chuckles. "And that's exactly why we end up getting them." Peggy turns in her seat to look at Rôvi. "How's the job hunting going, sweetie?" Rôvi answers gently with her usual grace. "I still haven't found anything. I don't think it's my lack of skills. I hear the same thing every time. Underqualified, overqualified, we'll call you. We're interviewing other candidates." But honestly, ain't Peggy. "I don't even need the money. I just want something to do, that's all." Earl glances at her in the rearview mirror. "Well, I told my sister Bonnie about you. She's got a partnership at a daycare. I overheard you tell Peggy some of your schooling is in childhood development, that right?" Rôvi nods. "Yes." Earl brightens. "Oh, that's perfect. Bonnie might give you a call. They may have a little part-time something for you. You'd help prep the kids' lunch, set out plates, clean up after, sanitize toys during nap time. Maybe even relieve some teachers for lunch, be a teacher's aide sometimes. That's something you'd be interested in?" Rôvi's face lights up. "Absolutely. Oh, Uncle Earl, I would love that." Peggy beams. "Oh, that'll be perfect for her, Earl." Earl continues. "They just gotta run the background check, which I know won't be no problem. And then you're good to go. They can always use extra help." Rôvi asks softly, "Would transportation be an issue?" Earl waves a hand. "Absolutely not, young lady. If me and Peggy gotta get you down there, we will. But Bonnie gets there early, and I know you're an early bird. She'll be glad to take you." Peggy suddenly leans forward, pointing. "Hey, there it is, Earl!" A large, beautiful house comes into view, the yard filled with tables and antiques. Earl breaks a little too sharply. "Peggy, you gotta tell me before we get to it so I don't have to do this abrupt stop." He laughs. They climb out of the truck. Immediately, a few eyes turn toward Rôvi, her flowing cloak, her sequins, the delicate crown in her hair. One of the estate sale organizers smiles warmly. "Oh, honey, your outfit is beautiful." Rôvi returns the smile with quiet grace. She's used to this. Earl and Peggy drift toward the antiques, dressers, old lamps, framed photos. Earl gravitates toward the yard tools, inspecting them like old friends. Peggy finds brand new sheets still in their packaging. Rôvi wanders toward the children's items, antique high chairs, wooden toys, porcelain dolls. A cuckoo clock catches her eye. The tiny bird perched inside the little door. She's enchanted. She buys it immediately. Earl finds an old school lawnmower with rotating blades, still in excellent shape. He pays for it and rolls it to the truck. He spots a toolbox full of well-kept tools and buys that too. Peggy buys her sheets. When everyone is done, they load their treasures into the truck. Earl starts the engine. "All right, ladies, time to head to the professional building." Peggy settles in. Perfect time, and we'll get there right on schedule. Rôvi looks out the window, the morning sun catching the sequins on her cloak. The truck pulls away from the estate sale and heads toward the seminar, toward the room where invisible battles will finally be named.
The elevator doors open. To the familiar hum of the professional building, security guards walk their rounds. A few parole officers escort clients down the hall. The receptionist is already busy with a line of people signing in for Dr. Blake's seminar. But today, something is different. Inside Blake's office, a deep, gravelly laugh fills the room. Bubba, Earl's older brother, the second oldest of the siblings, sits comfortably in a chair across from Blake's desk. Cowboy boots planted wide, checkered shirt tucked in, beard full and rugged, hands so calloused they look carved from oak. He carries that unmistakable old man strength, the kind that comes from decades of farm work. Blake, the youngest of all the siblings, beams with genuine joy. He loves his brothers. He loves their rough edges, their plain talk, their big hearts. He loves that they show up for him when they can. And today, Bubba has shown up. Blake leans forward, smiling. "So how's the wife and kids?" Bubba grins, voice gravelly and warm. "They doing great. They already in the classroom right now. Wanted to find a good seat. I can't wait to see Earl." Blake laughs softly. "Oh, Earl is going to be so happy to see you, boo." Taquan, sitting at his desk nearby, focus on paperwork, but he's clearly warmed by the family energy in the room. Bubba leans back. "So what's this meeting about, little brother?" Blake straightens slightly, slipping into his clinical cadence, the one his brothers always tease him about. "Well, first of all, it's a seminar, and we're covering 3 primary domains today: podiatric pathology, dermatological stress response behaviors, and craniofacial neuropathic pain syndromes." Bubba stares at him, then scratches his head. "What that mean?" Blake chuckles and switches to plain language. "It means we're talking about people who have foot problems, people who scratch their skin when they're stressed, and people who have chronic nerve pain in their face." Suddenly, Bubba's eyes widen. "Hold up! Did you say foot problems?" Blake nods. Bubba lifts his booted foot. "Well, look here." Before Blake can react, Bubba pulls off his boot, then his sock, and holds up his foot like a man presenting evidence in court. Blake's internal voice flickers. "Lord help me. My brothers always do this." He tries his best not to laugh. Bubba proudly continues. "You see this here? This is what you call feet problems." Blake comes around the desk and bends down to examine Bubba's foot visually, not touching, just assessing like the clinician he is. Bubba keeps going. "This here is from working on that farm boots all day, calluses, bunions. I don't even know what that thing is." He points at a spot and laughs. Last time I went to the doctor, they said it was some big fancy words. Sounded like fungus or something. Gave me a cream, cleared up, went back to work. Now it's back again. So I think I'm gonna need this group.
Suddenly, a knock at the door. Blake walks over and opens it. Earl and Peggy stand there, smiling. Bubba turns around. Earl freezes. Then both men break into identical, booming grins. Bubba! Earl! They collide in a massive Papa Bear hug. Two big, strong men who haven't seen each other in too long. Peggy beams at the sight.
Hello, Peggy.
Bubba says warmly. Peggy steps forward. Where's Ruby Joe? Is she here? Bubba nods proudly. Yes, ma'am, her and the boys are already in the classroom. Peggy beams. Well, I'm gonna go say hello. She slips out immediately. She knows when Bubba and Earl get together, it's gonna be a long session. Bubba and Earl sit down with Blake, falling right into old rhythms. Earl asks, how's the farm? Bubba leans back proud. Doing real good, got some solid hired hands now. We got a partnership with one of the local markets. Selling eggs, milk, all that prospers, just like when we were growing up with Mama and Daddy. You remember. Earl nods, nostalgia softening his face. Absolutely. Earl glances down at Bubba's boots. Look at them fancy boots, boy, I like those. Bubba puffs his chest a little. Yeah, they fancy. But I'm having some feet problems. Earl raises a brow. What you mean, feet problems? Bubba grins. Well, I came to this little group meeting. He glances at Blake. Seminar to see what's going on with my feet. Blake chuckles. They're gonna have one of those big fancy foot doctors today. Earl nods. Oh yeah, they are. I might ask him some questions about my feet too. After a few more minutes of catching up, the brothers stand. Bubba pat Blake on the shoulder. Proud of you, little brother. Blake smiles, touched. Love you too, Bubba. They wave at Taquan and head out inside the elevator. Bubba leans against the rail. So how's your oldest boy doing? Earl sighs with relief. Thankfully, keeping his nose out of trouble this time. He ain't in that old behavior anymore. I'm proud of him. Bubba nods. That's good, real good. Earl adds, you remember little Rôvi. Bubba nods. Yep, I sure do. Earl continues. Well, she's come back into town. She's gonna finish her schooling, and she's moved back home. Me and Peg practically adopted her. I can't wait for you to see her now that she's all grown up. Bubba smiles. Well, I look forward to it. The elevator dings. They step out into the classroom. Earl immediately spots Peggy talking to Ruby Joe, both laughing like old friends. Earl walks over, greets Ruby Joe and the boys. They were hoping to sit next to Ruby Joe and Bubba, but all the seats in that area are already filled. Earl looks toward the middle of the room, their usual spot. There sits Rôvi, who had already slipped away from Blake's office to find her seat. She sits quietly at the table directly in front of where Earl and Peggy usually sit. Earl leans over to Bubba and Ruby Joe, pointing subtly. There she is. That's the young lady I was telling you about, little Rôvi. Ruby Joe smiles, eyes wide. I was wondering who that young lady was. I haven't been able to take my eyes off her this whole time. Look at how she's dressed. I don't mean to be mean or nothing, but is she, part of some spiritual group or something. Bubba adds, is she one of them witch people? Earl and Peggy giggle. Peggy says, oh no, sweetheart, that's just how she is. She's always been artistic and she's always been unique. That's just her. She's a good lady. I'll introduce you after we have our lunch. Earl adds, yeah, she's a good kid. Okay, we'll talk to y'all soon. They wave and head to their seats, right behind Rôvi. Earl and Peggy look over and realize Earl's sister Bonnie and his brother-in-law, Charles the Marine, are sitting to the right. They greet him. Charles, maintaining his professional composure, gives Earl a nod and a gentle smile. Bonnie is happy to see them. When Rich enters the room, scanning the space with that quiet alpha male sweep, the Marine clocks it immediately. Not as a threat, but as a familiar behavioral pattern he's seen in service. A man who checks exits. A man who checks faces. A man who checks energy. Professional. Control. Predictable. The Marine respects it. He gives Rich a small nod, the kind of nod men like them exchange without words. Rich returns it.
Rich walks over to the table where Rôvi is sitting. He notices the 2 empty chairs beside her. He greets her with a small smile. She smiles back, soft and warm. Hello. Rich turns to greet Earl and Peggy. They greet him back with familiarity. He sits down, slides his backpack under the table, and pulls a bottle of water from the side pocket, setting it neatly in front of him. Peggy looks over at Earl, eyebrows raised. Before she can open her mouth, Earl mutters, "Don't even think about it." Peggy huffs, "I wasn't going to say anything." Earl smirks, "Yeah right." Rôvi hides a small smile. The door opens again. Rocky walks in with his wife, hand in hand, proud, tall, steady. He takes a glance at Rich from the doorway and gives him an upward chin nod. Rich returns the same upward nod, that silent masculine greeting men like them exchange. Rocky and his wife walk to the table to the right of Rich and Rôvi. Rocky's wife sits on the left, closest to Rôvi. Rocky sits on the right. There's an empty chair beside him. At Rich's table, Rich sits on the left. An empty chair is between him and Rôvi. Rôvi sits on the right. Earl notices the arrangement. Usually those two sit far apart, he thinks. But I guess since Rich is low risk now, he knows what he's doing. The Marine notices too, quietly, professionally, but says nothing. Bubba looks over at Rocky, eyes widening. He leans toward Ruby Joe. Look at all them tattoos that guy's got on his neck and arms. He must have done some serious hard time. Ruby Joe leans in quickly. Shish. The facilitators begin wandering into the room, rolling suitcases, carrying folders. Some specialists enter as well, setting up charts and materials. Amethyst prepares the diffuser, adding drops of essential oils. Taquan organizes folders to hand out. Bubba leans toward Mary Jo, lowering his voice. "Hey, that's that midget Blake was telling me about, his partner." Before he can finish, Ruby Jo slaps her hand gently over his mouth. At the same moment, his teenage boys turn around sharply. "Dad, that's not what you're supposed to call them," one says. "They're called little people," the other adds. "The M word is a bad word. It's like saying the N word. You're not supposed to say that anymore." Bubba's face flushes with embarrassment. Oh, I'm sorry. I didn't know. Sorry about that. So what do we call them now?" Ruby Jo answers softly but firmly. "We call them human beings, darling. He's a man. He's a facilitator. And the condition he was born with is called dwarfism. But do not ever say the M word again." One of his sons adds. "And they like to be called little people too." Bubba nods quickly. "Oh, okay. Got it. He settles back, humbled but grateful. As the facilitators prepare their materials, a shadow moves across the glass window. Rich notices first, without turning his head. His eyes flick toward the glass. The Marine notices Rich noticing. And he notices the shadow too. A trained man recognizes another trained man's alertness. Blake walks to the door. 3 parole officers stand there. Before Blake even opens it, the Marine has already assessed posture, footwear, stance, demeanor, no threat indicators, standard protocol. He sees the military-issue boots, the same kind he's wearing, and knows instantly. Parole supervision, not enforcement, not tactical, routine. Blake opens the door. The officers enter quietly, respectfully, making no scene. They move to the back and sit. The Marine's internal assessment concludes. No threat, no escalation, no need to intervene. Everything is normal. He returns his attention to the front, calm and composed. Rich doesn't turn his head. He stays forward, elbow on the table, rubbing his chin, that same unreadable poker face. The facilitators continue preparing. The specialists continue organizing. Peggy glances back at the parole officers and whispers to Earl, "I guess they must be here for Rocky and Rich, just to keep an eye on things." Earl nods. Yep, it's protocol. Probably because Rich is up for early release review. This is just their way of making sure he's gonna be okay to release back into the general public. Peggy smiles, relieved. Oh, that's wonderful. But in the back of Earl's mind, a quiet thought he keeps to himself, he wonders if the parole officers have Rich back on a watch list because of that strange exchange with Rocky. The room hums with quiet anticipation. The seminar is moments from beginning.
Good morning, everyone. I'm grateful to see each of you here today. Not just because you showed up, but because you showed up for yourselves. What we're talking about today are things people carry quietly. Things people don't always have the language for. Things that get dismissed, minimized, or misunderstood. Today's seminar is divided into 3 sections, and each one addresses a different kind of invisible battle. First, we're going to talk about podiatric pathology, the foot conditions that affect mobility, comfort, and quality of life. Many people live with pain they've normalized for years. Second, we'll move into dermatological stress response behaviors, the skin picking, scratching, rubbing, and coping mechanisms that often develop in silence. And third, we'll explore craniofacial neuropathic pain syndromes, chronic nerve pain in the face that can be debilitating, misunderstood, and deeply isolating. Each of these topics affects the body. Each of them affects the mind. And each of them affects dignity. You'll hear from specialists today who work in these fields every day. You'll hear clinical explanations, practical strategies, and, if you choose, you'll hear from each other. This is a learning space. This is a safe space. And this is a judgment-free space. We're here to understand. We're here to educate. And we're here to restore dignity to experiences that are often carried alone. He pauses, letting the weight settle. Let's begin. Blake steps slightly to the side, gesturing toward the front row where the specialists sit. His tone shifts, still warm, but now precise, professional, and anchored. Our first specialist is Dr. Hart, a podiatric surgeon with over 20 years of experience in diagnosing and treating structural foot disorders, chronic pain, and mobility-related conditions. She'll be leading our first section on podiatric pathology. Dr. Hart gives a small nod to the room. For our second section, we have a collaborative team. Dr. Mercer, a dermatologist specializing in stress-related skin conditions, and Dr. Ellington, a behavioral psychologist who focuses on compulsive and anxiety-driven coping behaviors. Together, they'll walk us through the intersection of skin, stress, and behavior. Both specialists acknowledge the room. And finally, for our third section, we have Drive Hale, a neurologist who specializes in craniofacial neuropathic pain, including trigeminal neuralgia and other chronic nerve pain syndromes. She'll help us understand the neurological pathways behind facial pain and the treatment options available. Dr. Hale offers a calm, reassuring smile. Blake continues. You'll also see our facilitators throughout the seminar. Amethyst, who will help ground the room and guide emotional regulation. Taquan, who will provide community context and support. And of course, I'll be here to offer clinical interpretation and help connect the dots between each section. He steps back to center. Thank you all for being here. Let's begin with section 1. He gestures toward drive, heart. The floor is yours.
Blake steps forward again, clipboard in hand. The room quiets. He lifts the clipboard slightly. Dr. Blake, before we begin, I'm going to pass around our sign-in sheet. I'll hand it to the first person on the right. Please sign your name and pass it along. Once it reaches the end, we'll retrieve it. He hands the clipboard to the participant closest to the door. They begin passing it down the row. At the same time, Taquan moves with quiet efficiency. He walks to the farthest right of the classroom, the seat closest to the door, and hands the first participant a folder. They begin passing folders around the room, one by one. Blake continues speaking as the folders circulate. In your folders, you'll find an outline of today's seminar, a blank sheet for notes or questions, and pamphlets covering each of the topics we'll be discussing. Feel free to write down anything you'd like to ask, either publicly or privately. You're also welcome to come up during lunch and speak with any of us. He gives the room a moment to settle with their materials. Dr. Blake continues. And now, let's begin. He turns toward the front row. Dr. Hart stands, smooth and composed. She steps forward with the quiet confidence of someone who has spent decades treating pain people rarely talk about. She offers a small, reassuring smile. Good morning, everyone. I'm Dr. Hart, and I specialize in podiatric medicine, specifically, the structural, neurological, and dermatological conditions that affect the feet. She pauses, letting the room breathe. Now, I want to start with something simple. Most people ignore their feet until they can't. A few people chuckle softly, Bubba included. Your feet carry your entire body weight. They absorb shock. They stabilize you. They keep you mobile. And yet, they're often the most neglected part of the body. She clicks a small remote. A diagram of the foot appears on the screen. This is the basic structure of the foot. 26 bones, 33 joints, over 100 muscles, tendons, and ligaments. She gestures to the diagram. When even one of these structures is irritated, inflamed, or misaligned, it can affect your entire body, your knees, hips, back, posture, balance, and even your sleep. She steps closer to the audience. Today, we're going to talk about 3 categories of foot issues. Structural conditions, things like bunions, hammer toes, flat feet, high arches, plantar fasciitis. Dermatological conditions, calluses, corns, fungal infections, cracked heels, skin breakdown. Neurological conditions, nerve pain, numbness, burning, tingling, neuropathy. She glances around the room, making eye contact. Some of you in this room are living with one or more of these right now. Some of you have normalized pain that should never have been normalized. Bubba shifts in his seat, already nodding. Let's start with structural issues. She clicks again, an image of a bunion appears. A bunion is not just a bump. It's a progressive joint deformity. It can be caused by genetics, footwear, or repetitive stress. And it can absolutely affect your gait and balance. She moves to the next slide, plantar fasciitis. Plantar fasciitis is one of the most common causes of heel pain. It's inflammation of the connective tissue that supports your arch. It can feel like stepping on a knife first thing in the morning. Several people murmur in agreement. Now, dermatological issues. She clicks, images of calluses and fungal infections appear. Calluses form from pressure and friction. They're not just cosmetic, they're your body's way of protecting itself. But too much callus can actually cause pain and change the way you walk. She gestures to the fungal slide. And fungal infections, athlete's foot, toenail fungus, are extremely common. They're not a sign of poor hygiene. They're a sign of moisture, warmth, and environment. Boot wearers, I'm looking at you. And finally, neurological issues. She clicks, a diagram of nerve pathways appears. Nerve pain in the feet can come from diabetes, injury, compression, or chronic inflammation. Symptoms include burning, tingling, numbness, or sharp shooting pain. If you've been living with any of these symptoms, you are not alone. And you are not supposed to tough it out. Foot pain is not a character test. It's a medical condition. In a moment, I'll open the floor for questions. But first, I want to emphasize this. Your feet tell a story. And if you listen to them early, you can prevent years of pain. She nods toward Blake. Dr. Blake, I'll turn it back to you before we begin the Q&A.
Dr. Hart finishes her segment. The room is quiet, thoughtful. Then a hand shoots up. Blake inhales slowly, preparing himself. He loves his brother, but he already knows what's coming. Earl has learned to filter himself over the years. Bubba's Earl unfiltered, raw, and straight off the farm. Blake braces, but he smiles inside. This is family. Earl gives Bubba the floor with a nod. Bubba asks, "Yeah, I got a question." I already showed this to my little brother, but I work on a farm. I can be in my boots 16 hours a day out there with the cattle, walking in soggy water, sometimes out in the heat. Long hours. A few people nod. They know their life. Bubba continues. The difference between me and the military is that I can come home to my family and take the uniform off. A few veterans in the room chuckle. They don't know him, but the line lands. Blake presses his lips together, trying not to smile. Bubba continues. I've developed a few conditions. I can't remember those fancy big words. Maybe you can help me out, little brother. Blake's eyes soften. He holds back a grin, maintaining professionalism. Dr. Hart already knows where this is going. Bubba continues. I remember hearing something about an athlete. Blake and Dr. Hart both know he means athlete's foot. Bubba continues. And I remember hearing something about a fungus or something. He lifts one boot slightly. So I don't think there's any boots out there with them fancy air holes. We gotta wear these boots 'cause there's snakes where I live. The boots protect us. But my feet are so bad now, I'm not sure I can keep wearing them. Thankfully, I got plenty of hired hands taking up the slack. They're younger guys. They can handle it. I'm getting old. A few chuckles ripple through the room. Bubba continues. I can't handle being out there 16 hours like I used to. I've slowed down And unfortunately, my feet have paid the price for it. So, is there a way to reverse this? Or to correct it? The room quiets. Everyone leans in. 'Cause Bubba just asked the question half the room is afraid to ask. Dr. Hart steps forward, warm and steady.
Dr. Hart steps forward, her expression warm and steady. She doesn't laugh at Bubba. She doesn't rush him. She meets him exactly where he is, with dignity. Thank you for sharing that. Truly, what you just described is something I see every week in my clinic. Hardworking people who spend long hours on their feet, in boots that are protective but not breathable, in environments that are hot, wet, or unpredictable. She gestures gently toward his boots. Boots like yours are designed for safety, snakes, livestock, uneven terrain, but they trap heat and moisture. That combination alone can cause fungal infections, skin breakdown, calluses, and chronic inflammation. Bubba nods, relieved she understands. And you're absolutely right, there are no fancy air-hole boots for farm work. You're not doing anything wrong. You're doing what your job requires. Now, let's talk about what's happening to your feet. She holds up 3 fingers. You're dealing with a combination of moisture-related skin issues, likely fungal infections or athlete's foot. Pressure-related structural changes, calluses, maybe early bunion formation, maybe plantar fasciitis. Overuse and age-related wear, which is completely normal for someone who has worked as hard as you have. Bubba listens closely, his face open and earnest. Dr. Hart continues, can we reverse everything? Not completely. But can we correct, treat, and dramatically improve what you're dealing with? Yes, absolutely. Here's what I recommend for someone in your exact situation. Moisture control, rotating socks, using moisture-wicking liners, and applying antifungal powder before putting your boots on. Skin protection, treating fungal infections early, softening calluses safely, and preventing cracks. Structural support, inserts or orthotics designed for work boots, not the cheap kind, but the kind that redistribute pressure and reduce strain. Recovery time, giving your feet a chance to breathe when you're home, even if it's just an hour or 2. She pauses, letting him absorb it. Dr. Hart continues, and most importantly, you are not getting old in a way that means you have to give up what you love. You're experiencing the natural consequences of decades of hard work, and we can absolutely help you manage that. If you'd like, after the seminar I can take a quick look at your feet and give you a personalized plan. Nothing invasive, just guidance. Bubba nods, grateful. I'd appreciate that, ma'am. She smiles. Dr. Hart continues, and thank you again for asking that question. You just helped half the room. A ripple of quiet agreement moves through the audience. Blake watches his brother with pride and relief.
Dr. Hart finishes speaking, and the room is still. Bubba looks relieved, but also a little overwhelmed by the amount of information. Blake steps forward gently, his tone warm but unmistakably clinical. Bubba, what Dr. Hart just described is exactly what you and I have talked about before, but she explained it in a way that gives you the full picture. What you're experiencing is a combination of 3 things: environmental exposure, structural strain, chronic overuse, and none of that is your fault. Bubba nods, listening closely. Dr. Blake continues, you've spent decades working in conditions that are hard on the body: heat, moisture, long hours, heavy boots, uneven terrain. That's not weakness. That's wear and tear from a lifetime of providing for your family. A few people murmur in agreement. Dr. Blake continues, and I want to emphasize something Dr. Hart said. This is treatable. This is manageable, and you don't have to live in pain. He gestures toward Dr. Hart respectfully. Dr. Blake continues, she's one of the best in her field. And everything she just outlined, moisture control, skin care, orthotics, recovery time, those are evidence-based interventions. They work. He looks back at Bubba, eyes warm. Dr. Blake continues, and you're not getting old, in a way that means you're done. You're adapting. Your body is telling you it needs support. That's not failure. That's physiology. Bubba's shoulders relax. Blake continues, now addressing the entire room. And for everyone else here, if you've been ignoring foot pain, or chalking it up to age, or telling yourself to push through it, I want you to hear this clearly. Pain is information. It's not a moral test. It's not a character flaw. It's your body asking for help. He lets that land. Dr. Blake continues, so if Bubba's question resonated with you, you're not alone. And you're not supposed to suffer in silence. He nods toward Dr. Hart again. Dr. Blake continues, we'll open the floor for more questions in a moment. But Bubba, thank you. You just opened the door for a lot of people. Bubba gives a small, proud nod.
Tarquin sits forward slightly, hands folded, posture composed. His voice is calm, measured, and resonant, the voice of a man who understands community behavior, human dignity, and the psychology of silence. Tarquin speaks. Bubba, I'd like to offer a perspective from the community lens. In many communities, rural, urban, working class, and everything in between, people often normalize pain. They push through discomfort because that is what they were taught. They prioritize responsibility over well-being. They assume that physical strain is simply part of the role they occupy. What you described is not uncommon. In fact, it is deeply familiar. People work long hours, they stay on their feet, they endure harsh environments, and they rarely pause to consider the long-term impact on their bodies. And because of that, many individuals hesitate to speak up. They don't want to appear weak. They don't want to inconvenience anyone. They don't want to admit that something hurts. So when you raised your hand and articulated your experience, you did something important. You modeled honesty. You demonstrated that acknowledging pain is not a failure, it is a form of self-respect. A quiet shift moves through the room. Tarquin continues. You also gave others permission to recognize their own discomfort. You opened a door that many people are hesitant to walk through. That is not a small contribution. That is leadership. And from a community standpoint, I want to emphasize this. Pain is not a measure of character. Endurance is not the same as health. And seeking support is not a sign of weakness, it is a sign of wisdom. He gives Bubba a small, respectful nod. Tarquin continues. Thank you for speaking up. You helped more people than you realize. The room absorbs his words, quiet, thoughtful, connected.
Blake steps forward again, scanning the room with calm professionalism. Does anyone have any other questions, foot-related, before we move on? A hand rises. Rocky. Blake gives him the floor with a respectful nod. Rocky stands. His posture is steady, but there's a quiet weight behind his eyes, the kind of weight that comes from lived experience. Before he speaks, Bubba leans toward Ruby Joe and whispers, "See, I told you he was in prison." Ruby Joe nudges him sharply in the ribs. "Shush." Rocky speaks. "I spent time in prison. And this is something a lot of people don't talk about." The room shifts. Subtle, attentive. Rocky continues. "While I was in, I developed foot fungus. It got worse and worse. I reported it. They gave me some powder, but it just kept getting worse." Dr. Hart listens with full clinical attention. Rocky continues. "The problem was, even when it healed up, I was still in the same environment. Same showers, same floors, same moisture, same heat, same shoes. So I kept coming into contact with it again. When I got out, I noticed I still had itching from time to time. I've been to the doctor. They gave me powder, but it feels like it lowered the immunity on my feet. Like my skin is sensitive now. Like it reacts to everything." A few men in the room nod quietly. They know exactly what he means. Rocky continues, and inside, we don't get to wear the kind of shoes that are best for our feet. We wear whatever they give us. Hard soles, no support, no breathability. That's how I ended up with severe bunions. So I was wondering if you could touch on that. He sits. The room is silent, not from discomfort, but from recognition.
Dr. Hart steps forward, her expression soft but focused. She doesn't flinch. She doesn't pity him. She meets him with the same respect she would give any patient in her clinic. Dr. Hart speaks. Rocky, thank you for bringing that forward. What you described is not only common, it is medically well understood. And you explained it clearly. Fungal infections thrive in environments that are warm, moist, and shared. Correctional facilities, by design, create those conditions: communal showers, limited ventilation, and footwear that is not breathable. None of that is a reflection of personal hygiene. It is a reflection of the environment. Rocky nods, relieved she understands. Dr. Hart continues. When a fungal infection is treated but the environment remains the same, reinfection is extremely likely. That is why the powder helped temporarily but didn't resolve the problem long-term. She continues, her tone steady and clinical. Now, regarding the sensitivity you're experiencing. Chronic fungal infections can weaken the skin barrier. When the skin barrier is compromised, the feet become more reactive, to moisture, to friction, to heat, even to certain fabrics or soaps. That sensitivity you're describing is a very real, very common after effect. She gestures gently toward his shoes. Dr. Hart continues, and you're absolutely right about footwear. Incarceration footwear is often rigid, flat, and lacking in support. When someone wears those shoes for months or years, especially on concrete floors, it can lead to structural changes, including bunions, joint stress, and altered gait patterns. Rocky listens closely, his jaw tightening with recognition. Dr. Hart continues, none of this is your fault. These are predictable medical outcomes of an environment you had no control over. The good news is that we can treat every part of what you described. She holds up 3 fingers. First, we can rebuild the skin barrier. That involves antifungal treatment, moisture control, and barrier repair creams that strengthen the outer layer of the skin. Second, we can address the sensitivity. Once the skin barrier is restored, the reactivity decreases significantly. It takes time, but it is absolutely achievable. Third, we can correct the structural issues. Bunions and pressure-related deformities can be managed with proper footwear, orthotics, and, in some cases, targeted physical therapy. She pauses, making sure he feels seen. Dr. Hart continues, and I want to emphasize this. Your experience is not unusual. Many individuals who have been incarcerated leave with foot conditions that were never properly treated. You are not alone, and you are not an outlier. If you'd like, I can examine your feet after the seminar and give you a personalized plan. Nothing invasive, just a clear path forward. She gives him a respectful nod. Dr. Hart continues, and thank you again for speaking up. You just gave voice to an issue that affects far more people than most realize. The room is silent, not heavy, but thoughtful. Rocky nods once, firmly, grateful.
Blake steps forward again, not abruptly, not to take over, but to bridge what Rocky lived and what Dr. Hart explained. His tone is calm, steady, and deeply respectful. He looks at Rocky first, then at the room. Dr. Blake speaks. Rocky, I want to translate what you just described through a clinical lens, because your experience is not only valid, it is medically predictable. He lets that land. No judgment, no pity, just truth. Dr. Blake continues, when someone is in an environment where they cannot control their footwear, their hygiene conditions, or their exposure to moisture and shared surfaces, the body adapts in ways that are not always healthy. That isn't a personal failing. That's physiology responding to circumstances. He gestures gently toward Rocky, but his words are for everyone. Dr. Blake continues, Incarceration environments create three specific medical challenges. Constant re-exposure to fungal organisms in communal showers and damp surfaces. Inadequate footwear that forces the foot into unnatural positions for long periods. Chronic inflammation from walking on hard surfaces without proper support. He pauses, for comprehension. Dr. Blake continues, so when you said the infection kept coming back, that wasn't because the treatment failed. It was because the environment kept reintroducing the same organism faster than your skin could heal. Dr. Blake continues, and when you said your feet feel more sensitive now, that is a real, documented phenomenon. Chronic fungal infections weaken the skin barrier. Once that barrier is compromised, the skin becomes reactive, almost like it's on high alert. That sensitivity is not in your head. It's not overreacting. It's not weakness. It's a biological response to long-term irritation. And the bunions you mentioned, those are a direct result of footwear that doesn't match the natural shape of the foot. When someone wears rigid, narrow, or unsupportive shoes for months or years, the bones adapt to the pressure. Again, not a personal failing. A predictable outcome. You didn't do anything wrong. You didn't neglect your health. You didn't cause this. You were in an environment where your body had to endure conditions it wasn't designed for. And now that you're out, your body is still adjusting. That's normal. And with the right treatment, the kind Dr. Hart outlined, your feet can recover. Not overnight, but steadily. He gives Rocky a small, respectful nod. Dr. Blake continues, thank you for naming something that many people carry silently. You gave language to an experience that deserves to be understood, not hidden. Rocky nods back, grounded, dignified, seen. The room feels different now, more honest, more connected, more human.
Tarquin has been listening with full attention, posture composed, hands folded, expression thoughtful. When Blake finishes, Tarquin steps forward. Tarquin speaks. Rocky, I'd like to offer a community lens perspective on what you just shared. In many communities, especially among individuals who have experienced incarceration, there is a strong tendency to minimize physical discomfort. People adapt. They endure. They normalize conditions that would be considered unacceptable in other environments. And because of that, many people leave those environments with medical issues they've never spoken about. Not because they don't care, but because they were conditioned to function in circumstances where personal well-being was secondary to survival. What you described, the recurring infections, the sensitivity, the structural changes, these are not isolated experiences. They are shared realities for many individuals who have lived in restrictive environments with limited control over hygiene, footwear, or exposure. And I want to emphasize something important. You articulated your experience clearly, respectfully, and without shame. That matters. When someone with lived experience speaks openly, it creates space for others to recognize their own symptoms. It reduces stigma. It challenges the idea that pain should be hidden or endured in silence. From a community standpoint, your question did more than address a medical issue. It acknowledged a shared truth, one that is often overlooked or dismissed. Thank you for naming it. You helped normalize a conversation that many people have been waiting for permission to have. The room absorbs his words, thoughtful, connected, dignified. Rocky nods back, steady and grounded.
Dr. Blake scans the room. Before we transition into Section 2, there's one more foot condition we need to bring into the conversation: ingrown toenails. They're extremely common, and they're often overlooked until they become severe. A hand rises from the middle row. A construction worker, broad-shouldered, sun-worn, wearing the kind of boots that tell their own story. Blake nods, giving him the floor. The construction worker speaks. Yeah, I can speak on that. I worked construction. Long shifts, sometimes 16, 18 hours. We're required to wear steel toe boots the whole time. No exceptions. A few military participants nod subtly. They understand rigid boots. The construction worker continues. After a while, the pressure on the front of the boot starts pushing the nail into the skin. I've had ingrown toenails so bad I could barely walk, but I still had to finish the shift. I've had 'em get infected, swell up, all that. I always thought it was just part of the job. But is there a way to prevent it? Or at least keep it from getting that bad? The room leans in. Dr. Hart steps forward, ready to answer.
The construction worker finishes speaking. His voice was steady, the voice of a man who has worked through pain because the job required it. Dr. Hart steps forward with calm authority. Her tone is warm, precise, and deeply respectful. Thank you for bringing that forward. What you described is extremely common in occupations that require long hours in rigid, protective footwear, construction, manufacturing, warehouse work, and even certain military roles. She gestures gently toward his steel toe boots. Dr. Hart continues, steel toe boots are essential for safety, but they create a perfect environment for ingrown toenails. They compress the front of the foot, limit natural toe movement, and place constant pressure on the nail edges. Over time, that pressure forces the nail to grow into the surrounding skin. A few military participants nod subtly, they understand the pressure of rigid boots. Dr. Hart continues, when you combine that with long shifts, 12, 16, even 18 hours, the nail doesn't get any relief. The skin becomes irritated, inflamed, and eventually infected. That's why you experienced swelling and pain. She continues, her tone steady and clinical. And I want to emphasize something important. This is not a sign of poor hygiene. This is not a sign of neglect. This is a predictable medical outcome of the footwear your job requires. The construction worker nods, relieved. Dr. Hart continues, now, let's talk about prevention and management. She holds up 3 fingers. 1. Pressure relief. The most effective prevention strategy is reducing pressure on the nail edges. That can be done with wider toe box steel toe boots, protective toe caps that redistribute pressure, orthotics that stabilize the foot and reduce forward slide. Even small changes in pressure can dramatically reduce ingrown toenail formation. 2. Nail care. Proper nail trimming is essential. Nails should be cut straight across, not curved, to prevent the edges from digging into the skin. Many people unintentionally worsen ingrown nails by rounding the corners. 3. Skin and infection management. If the area becomes red, swollen, or painful, early treatment is key. Warm soaks, topical antibiotics, and in some cases, a minor in-office procedure can correct the nail's growth pattern. And I want to be clear. If you've been working through this pain, you're not alone. Many people in physically demanding jobs normalize discomfort because the work doesn't stop. She looks around the room, including the military participants who are quietly nodding. Dr. Hart continues, but ingrown toenails are treatable. They're preventable, and you don't have to accept them as part of the job. If you'd like, I can take a look after the seminar and give you a personalized plan based on your specific boot requirements and shift length. The construction worker nods, grateful, not embarrassed, not singled out, just seen. The room absorbs her words, thoughtful, grounded, connected.
Dr. Hart finishes her explanation. The construction worker nods, absorbing every word. Blake steps forward, not to repeat her, not to overshadow her, but to translate her medical precision into human terms the entire room can feel. His tone is warm, steady, and deeply respectful. Dr. Blake speaks. What Dr. Hart just described is exactly what we see in people who work long, physically demanding shifts in rigid footwear. And I want to translate that through a clinical lens so the entire room understands the mechanics behind what you're experiencing. He gestures gently toward the construction worker's boots. Dr. Blake continues. When you're in steel toe boots for 12, 16, sometimes 18 hours, the front of the boot becomes a constant pressure point. That pressure pushes the nail into the surrounding skin. Over time, the skin becomes inflamed, the nail edge embeds deeper, and infection becomes more likely. This isn't about hygiene. It isn't about neglect. It isn't about doing anything wrong. It's about physics and anatomy. When the nail is compressed repeatedly, the tissue responds exactly the way yours did. A few military participants nod, they know the feeling. Dr. Blake continues. And I want to highlight something Dr. Hart said that's important. People in physically demanding jobs often normalize pain. They assume it's part of the work. They push through it because the job doesn't stop. But clinically, an ingrown toenail is not a minor issue. It's a structural problem caused by repeated pressure, and it can absolutely be prevented and treated. The strategies she outlined, wider toe boxes, pressure redistribution, proper trimming, early intervention, those aren't luxuries. They're evidence-based interventions that can prevent months of pain. And I want to acknowledge something directly. You've been working through a level of discomfort that most people underestimate. That doesn't make you tough, it makes you human. And now that you understand the mechanics behind it, you have options. The construction worker nods, steady and appreciative. Blake finishes with a quiet, dignifying clarity. Dr. Blake continues. Thank you for bringing this forward. You helped normalize a condition that affects far more people than most realize. The room absorbs his words, thoughtful, connected, grounded.
Bubba leans over to Ruby Joe and whispers in pride. Look what all that college education did for my little brother. I'm so proud of him. Ruby Joe gently smiled. I know you are, darling. I'm proud of him too. Tarquin steps forward. His expression is thoughtful, grounded, the steady presence of a man who understands people, systems, and the quiet burdens of labor. I'd like to offer a community lens perspective on what you just described. In many working-class communities, construction, manufacturing, warehouse work, transportation, people often normalize physical pain. They push through discomfort because the job requires it, the schedule demands it, and the culture reinforces it. Long shifts in rigid boots, constant pressure on the feet, and limited opportunities to rest or adjust footwear, these conditions create predictable medical issues. But because they're so common, people often assume they're just part of the job. What you described isn't unusual. It's familiar. Many people in physically demanding roles experience the same symptoms but never talk about them. Not because they don't care, but because they've been conditioned to endure. And I want to highlight something important. By speaking up, you didn't just ask a medical question. You named a shared reality, one that affects thousands of workers who spend their lives on concrete, in steel-toe boots, under pressure to keep moving. He folds his hands again, posture grounded. From a community standpoint, your question helps shift the narrative. It reminds people that pain is not a requirement of hard work. It's a signal, and acknowledging it is not weakness, it's wisdom. He gives the construction worker a respectful nod. Tarquin continues. Thank you for bringing this forward. You helped normalize a conversation that many people have been carrying silently. The room absorbs his words, thoughtful, grounded, connected.
Dr. Blake steps forward, composed, voice steady. Before we move on to the section in this seminar, does anyone have any other questions regarding the foot? Blake scans the room. No one raises their hand. Alright, we are now moving on to skin coping behaviors. In this section, we're going to focus on skin scratching as a coping behavior. Not as a habit, not as a flaw, but as a response the body uses when stress, emotion, or sensory input becomes difficult to manage. He turns slightly toward the specialists. Dr. Blake continues. To guide us through this, we've asked our behavioral psychologist and psychodermatologist to walk us through what actually happens in the mind, the nervous system, and the skin. He steps back, giving them the floor.
The psychodermatologist steps forward. Her posture is calm, her expression focused, the presence of someone who understands both the skin and the human experience behind it. Her voice is steady, warm, and clinically precise. 1. The skin is a sensory organ that reacts to stress. When we talk about skin scratching as a coping behavior, we must begin with one truth: the skin is not passive. It is a sensory organ that responds directly to stress, emotion, and internal tension. She gestures gently toward her own forearm. She continues. The skin contains an enormous network of nerve endings. When stress rises, those nerve endings become more reactive. They send signals that feel like itching, tingling, crawling, or pressure, even when nothing is physically wrong. She pauses, letting the room absorb the clarity. 2. Stress changes the skin's sensitivity. During emotional overload, the body releases stress hormones. These hormones increase inflammation, heighten sensitivity, and make the skin more responsive to even minor sensations. This is why people often scratch during anxiety, overstimulation, or moments of internal strain. The skin becomes the place where the body expresses what the mind is carrying. 3. Scratching creates a momentary shift in sensation. When someone scratches, they are not simply responding to an itch. They are creating a new sensation, one that temporarily overrides the internal discomfort. She explains without judgment. For a brief moment, the brain shifts its focus from emotional tension to physical sensation. That shift can feel grounding, relieving, or clarifying. This is why scratching can become a repeated coping behavior. 4. The relief is real, but temporary. The relief someone feels from scratching is not imagined. It is a genuine neurological response. But it is temporary. And because the relief fades quickly, the urge to scratch can return just as quickly. This is how the skin becomes the outlet. Not because someone chooses it, but because the nervous system learns that scratching provides a moment of relief. 5. Repeated scratching changes the skin. When scratching becomes frequent, the skin begins to change. It can become more sensitive, more reactive, and more prone to irritation. Micro-injuries form. The barrier weakens. Inflammation increases. These changes make the skin more likely to send signals that feel like itching or discomfort. And that increases the urge to scratch. This is how a cycle forms. 6. This is not a flaw, it is a stress response pathway. It is important to understand that skin scratching as a coping behavior is not a character issue. It is not a lack of discipline. It is not a failure. She looks around the room with quiet authority. It is a stress response pathway. A learned pattern. A way the body attempts to regulate internal tension when other strategies are not available or not yet developed. 7. The goal is not to shame the behavior, but to understand it. When we understand why the skin becomes the outlet, we can begin to interrupt the cycle. We can identify triggers, recognize early urges, and introduce alternative forms of grounding that support the nervous system without harming the skin. That is the foundation. Now that we understand the skin's role, the behavioral psychologist will explain the behavioral and neurological patterns that maintain the cycle. She returns to her seat, composed, authoritative, and deeply human.
The behavioral psychologist rises after the psychodermatologist finishes. He stands with calm, grounded authority, the presence of a man who understands the nervous system, human behavior, and the quiet ways people try to regulate themselves. His voice is steady, warm, and clinically precise. 1. Scratching is a learned stress response behavior. When we look at skin scratching through a behavioral lens, we see a very clear pattern. Scratching is not random, it is not accidental, it is a learned stress response behavior, a way the nervous system attempts to regulate internal tension. He speaks with clarity, not judgment. The body experiences discomfort, emotional, cognitive, or sensory. The brain searches for a way to release that discomfort. Scratching becomes the outlet because it creates a momentary shift in sensation. 2. The nervous system pairs relief with the action. He continues with clinical precision. When someone scratches during stress, the brain registers a brief sense of relief. That relief may last only a second or two, but it is enough for the brain to make a connection. When I scratch, I feel better. He pauses, letting the room absorb the truth. This is how a coping behavior forms. Not through conscious choice, but through reinforcement. The nervous system pairs the action with the relief. 3. The stress-scratch cycle develops. He shifts into deeper explanation. Over time, This creates what we call the stress-scratch cycle. Stress or emotional overload rises. The body becomes restless or tense. The urge to scratch appears. Scratching provides brief relief. The brain remembers that relief. The urge returns more quickly the next time. He speaks with calm authority. This cycle is not a sign of weakness. It is a sign of a nervous system trying to cope with more than it can comfortably hold. 4. Scratching often begins outside of awareness. His tone remains steady and compassionate. Many people scratch without realizing it. The behavior often begins in moments when the mind is occupied, reading, waiting, thinking, trying to fall asleep, or managing emotional intensity. The body acts before the conscious mind catches up. That is not carelessness. That is the nervous system doing what it has learned to do. 5. Scratching is a form of grounding, but an incomplete one. He gestures gently, illustrating the concept. Scratching creates a physical sensation that temporarily interrupts emotional or cognitive overload. In that sense, it is a form of grounding. But it is incomplete, because the relief is brief and the underlying stress remains. This is why the urge returns. The behavior addresses the sensation, not the source. 6. The behavior is not the problem, the overwhelm is. It is important to understand that scratching is not the core issue. The core issue is the internal overload that precedes it. Scratching is simply the body's attempt to manage that overload. When we shift our focus from, "Why do I scratch?" to, "What is my body trying to manage?" we move from shame to understanding. 7. Change begins with awareness, not force. He concludes with grounded clarity. The goal is not to force the behavior to stop. The goal is to understand the pattern, recognize the early signals, and introduce alternative forms of grounding that meet the same need without harming the skin. When we understand the behavior, we can support the nervous system instead of fighting it. That is how real change begins. He steps back, composed, authoritative, and deeply human.
The psychodermatologist steps forward again, her tone steady and grounded. 1. Skin scratching exists on a spectrum. When we talk about skin scratching as a coping behavior, it's important to understand that it exists on a spectrum. On one end, we have occasional stress-related scratching. On the other end, we have clinical conditions that involve the skin more intensely. She pauses, then continues with clarity. 2. Dermatillomania, skin picking disorder. Her voice remains calm, precise. Dermatillomania, also known as excoriation disorder, is a condition where a person repeatedly picks, scratches, or digs at their skin. This is not simply scratching an itch. It is a compulsive behavior driven by internal tension, anxiety, or sensory discomfort. She explains without judgment. People with dermatillomania often describe a rising urge or pressure before picking, a sense of relief or release during the behavior, difficulty stopping once it begins, shame or frustration afterward. This is not a character flaw. It is a neurobehavioral condition where the skin becomes the primary outlet for emotional or sensory overload. She continues, dermatillomania can lead to visible marks, scarring, or irritation. But the behavior is not about harming the skin. It is about trying to regulate something happening internally. 3. Dermatographism, skin writing. She shifts into the second condition. Dermatographism is very different. It is not a coping behavior. It is a physical skin response. In dermatographism, the skin becomes so reactive that even light scratching or pressure causes raised, red lines to appear. She gestures gently to illustrate. This is a physiological condition, not a behavioral one. The person is not scratching to cope. The skin is simply over-responsive. It reacts dramatically to minor friction. She clarifies the distinction. Dermatographism is about how the skin behaves. Dermatillomania is about how the person copes. 4. Why these two conditions matter in this section. We include both conditions here because they help us understand the full picture. Some people scratch because the skin is reactive. Some people scratch because the nervous system is overloaded. Some people experience both at the same time. She concludes her portion with clarity. Now that we've covered the skin's role, including dermatillomania and dermatographism, The behavioral psychologist will explain the behavioral and neurological patterns that maintain these responses. She steps back, composed and confident. The male behavioral psychologist steps forward. His tone is warm, grounded, and clinically precise. 1. Dermatillomania is a coping behavior rooted in the nervous system. Dermatillomania is not simply picking at the skin. It is a coping behavior driven by internal tension. The nervous system becomes overloaded, and the brain reaches for a behavior that provides immediate relief. He continues, the relief is real. The problem is that it is brief. And because the relief fades quickly, the urge returns. 2. Dermatillomania follows a predictable cycle. He outlines it clearly. The cycle looks like this. Internal stress or emotional overload builds. The urge to pick or scratch rises. The behavior provides a moment of relief. The brain remembers that relief. The urge returns more quickly next time. He pauses. This is not a conscious choice. It is a reinforced pattern. 3. Dermatographism is not behavioral, and that distinction matters. He clarifies the difference from his side. Dermatographism is not a coping behavior. It is not driven by emotion or stress. It is a physical skin response. The person is not seeking relief. The skin is simply reactive. He continues, dermatillomania is a behavior. Dermatographism is a condition. 4. Why people confuse the two. People often confuse these conditions because both involve the skin, but the motivations, triggers, and patterns are completely different. He explains, in dermatillomania, the behavior is the response. In dermatographism, the skin is the response. 5. Understanding the difference helps us respond correctly. He concludes with grounded clarity. When we understand whether the skin is reacting or the person is coping, we can choose the right support. Grounding strategies, sensory alternatives, behavioral interruption techniques, skin protective routines, emotional regulation tools. The goal is not to force change, but to understand the pattern and support the nervous system. He steps back, composed, authoritative, and deeply human.
Tarquin steps forward. He waits until the specialists have fully finished, then rises with calm authority, the kind of presence that makes the room feel understood rather than examined. His voice is steady, warm, and deeply grounded in lived community experience. Tarquin speaks. I want to speak to what we've just heard from a community perspective, because everything the specialists described is far more common than people realize. In many communities, working class, military, caregiving, high-stress environments, people develop coping behaviors they never talk about. Skin scratching, picking, rubbing, or reacting strongly to touch are things many individuals experience privately. They assume they're the only ones. They assume it's strange or unusual. It isn't. What the psychodermatologist and behavioral psychologist explained is something I see all the time. People carrying more internal pressure than they can comfortably hold, and their bodies finding ways to manage that pressure. Some people pace. Some clench their jaw. Some tap their foot. And some turn to the skin. Dermatillomania, stress scratching, and even strong skin reactivity like dermatographism, these are not rare. They're not signs of weakness. They're not failures. They're human responses to stress, overload, or sensitivity. He lets the truth settle. Tarquin continues, and I want to emphasize this. Most people who do these things have never said a word about it. Not because they're hiding something, but because they've never had a space where it was safe to name it. So when we talk about these behaviors today, we're not exposing anyone. We're normalizing something that has been happening quietly in homes, workplaces, classrooms, and communities for years. You are not alone in this. You are not unusual. You are not the exception. You are part of a very human pattern that deserves understanding, not judgment. He steps back, composed, grounded, and deeply dignifying.
The psychodermatologist and behavioral psychologist return to their seats. The room is quiet, not heavy, but thoughtful. People are processing what they've just learned. Blake steps forward first, his tone steady and composed. Dr. Blake, thank you both. Before we move forward, we want to take a moment to understand how this shows up in real life. We've talked about the science. We've talked about the behavior. Now we want to understand the lived experience. If you feel comfortable, we'd like to ask a simple question. He looks around the room, steady, warm, never intrusive. Who here has experienced stress-related skin behaviors? Scratching, picking, rubbing, or reacting strongly during moments of overwhelm. There is a quiet pause, the kind that signals safety, not hesitation. Hands begin to rise, some slowly, some immediately, some with visible relief, and then, for the first time, Rôvi raises her hand. Blake gives a small, respectful nod, not to her specifically, but to the room as a whole. Thank you. This is more common than people think. The room settles into a shared understanding, grounded, connected, ready for what comes next. The room is quiet after the facilitators ask the question. Hands are raised across the space. And then Rôvi stands. Her black cloak catches the classroom lights, tiny sequins shimmering like constellations. Every head turns toward her. A few people lean in, whispering to the person beside them, not out of judgment but fascination. Her presence is striking, mysterious, elegant. Rich hears a few of the murmured compliments from where he sits. He doesn't react outwardly, but he listens. No one knows what she is about to say. Not Peggy, not Earl, not Bubba or Ruby Joe. Only Drive. Blake and Tarquin know pieces of her history, not the full story, just enough to understand the weight of this moment. The room stills. You could almost hear the air pause. Rôvi lifts a hand gently toward Amethyst. Amethyst understands immediately and passes her the microphone with a warm, encouraging smile. Rôvi's voice is soft, a whisper-like tone that carries surprising strength. Rôvi speaks. This is my story. And I'm grateful to be here today, because I'm hoping this will help me understand something I've carried since childhood. The room leans in. Rôvi continues. When I was very young, at an age where I didn't know right from wrong, and I couldn't protect myself, I developed a coping behavior. I didn't have the language for it then. I didn't understand stress, or fear, or survival. I only understood that something around me felt unsafe, and I didn't know how to make it stop. The facilitators nod gently. They understand exactly what she is doing, speaking truth in a safe, coded, dignified way. Rôvi continues. My mind wasn't developed enough to process what I know now. I was in an environment where the people who should have protected me didn't. And I turned that confusion and fear inward. Not because I wanted to harm myself. Not because I wanted to disappear. But because I was overwhelmed, and I didn't have any other tools. I've worn this veil for years. Some people think it's part of my style. Some think it's a cultural choice. Some think it's just part of my mystery. She reaches up and gently removes the lace covering. For the first time, the room sees her full face. There is a quiet shift, not shock, not judgment, but understanding. The marks are visible now. Not graphic. Just present, the history of a child who survived something she never should have faced. She turns slowly so the back of the room can see, then faces forward again. Peggy's eyes widen. Earl's breath catches. Bubba and Ruby Joe exchange a look, not pity, but realization. Rich doesn't move. He simply watches her with a new kind of respect, a deeper kind of curiosity. Rôvi continues. What you see on my face, this is not something I did as an adult. This is something that happened when I was a child trying to protect myself in the only way I understood at the time. She pauses, steady. Rôvi continue. I was taken in by Aunt Peggy's neighbor. They got me the help I needed. Therapy, safety, a real home. I grew up. I healed. I built a life. I studied childhood development so I could understand what happened to me, and so I could help other children who might feel the way I once felt. But there are two questions I've never been able to answer. And that's why I'm here. First, Why did that coping behavior feel like relief to my younger self? Why did my mind choose that path? The specialists nod, they know exactly what she's asking. Rôvi continues. And second, these marks, I've learned to cover them when I need to. Makeup helps. But I want to understand them from a dermatology perspective. What they are, how they formed, and what options I have. She places the veil back over her nose and mouth, not to hide, but to reclaim her presentation. Then she sits. Rich watches her adjust her cloak, and something shifts inside him. He sees her differently now, not as a mysterious woman, but as someone who survived without support, without privilege, without protection, and still chose education, healing, and purpose. Peggy's eyes glisten. Earl's jaw tightens with protective understanding. Bubba whispers to Ruby Joe, quietly humbled. And now, the specialists step forward to respond. The room is silent after Rôvi sits. Not heavy, reverent. The psychodermatologist and behavioral psychologist exchange a brief, professional glance. They rise together, walking toward Rôvi with calm, grounded presence. They stop at a respectful distance. 1. The psychodermatologist speaks first. Her voice is warm, steady, and clinically precise. Rôvi, thank you. What you shared was courageous, and you shared it with remarkable clarity and care. I want to begin by saying this: the marks you carry are not a reflection of who you are. They are a reflection of what you survived. She pauses, letting the room absorb the truth. From a dermatology perspective, what we're seeing is consistent with skin that experienced repeated stress and inflammation during a time when the skin was still developing. Childhood skin is delicate. It responds strongly to emotional and environmental pressure. She continues, still gentle. The patterns you described, the urge to touch, scratch, or focus on the skin during overwhelming moments, are consistent with stress-related coping behaviors in children who do not yet have language or support. She gestures softly toward Rôvi's veil. As for covering the marks, makeup is absolutely a valid option. There are also dermatology-grade concealers and treatments that can soften the appearance if you choose. But I want to be clear, there is nothing here that needs to be hidden for your worth or dignity. Any choice you make is about comfort, not correction. She steps back slightly, signaling that the behavioral psychologist will now speak. 2. The behavioral psychologist responds. His tone is calm, grounded, and deeply respectful. Rôvi, what you described is something we see in children who are overwhelmed, unsupported, and trying to make sense of situations far beyond their developmental capacity. When a child is in an unsafe environment, the nervous system looks for any way to regain a sense of control. Sometimes that control becomes internal, focusing on the body, the skin, or a specific sensation. It is not self-destruction. It is self-protection. You mentioned that the behavior felt relieving. That makes perfect sense. When a child cannot change the environment, the body finds a way to create a moment of predictability. A sensation they can control. A response that belongs to them. He pauses, letting the room breathe. He continues. And the coded language you used, we understood it. You communicated it safely, and we heard you. What you did as a child was not a choice made with adult reasoning. It was a survival response from a mind that was trying to stay safe in the only way it knew. The fact that you grew, healed, sought education, and now stand here asking these questions, that speaks to resilience, not damage. Your skin tells a story of survival. And your behavior tells a story of adaptation. What happened to you was not your fault. And the way you coped was the way your young mind tried to stay safe. We're here to help you understand the why. And to help you move forward with clarity, not shame. He stepped back, allowing the room to absorb the moment.
Dr. Blake steps forward with calm authority. His voice is steady, warm, and clinically grounded. 1. Blake begins by honoring the courage, not the content. Rôvi, thank you. You shared something profoundly difficult with remarkable clarity and restraint. You protected yourself, and you protected the room, while still telling the truth of your experience. That takes strength. He lets the room breathe. 2. Blake translates the childhood coping behavior into clinical language. I want to translate what you described into clinical terms, so everyone here understands what was happening in your young mind and body. When a child is in an unsafe or overwhelming environment, the nervous system goes into survival mode. At that age, the brain does not have the ability to reason, plan, or articulate what it needs. It only knows that something feels frightening or confusing. In those situations, children often develop coping behaviors that help them feel a sense of control. These behaviors are not choices. They are instinctive responses to emotional overload. 3. Blake explains why the behavior felt relieving. You asked why the behavior felt relieving. The answer is that your young nervous system found a way to create a sensation it could control. When the external world felt unpredictable, your body created an internal focus point. He pauses, letting the room absorb the meaning. He continues. That sensation, even though it was not healthy, gave your younger self a moment of grounding. A moment where the fear or confusion quieted. That is why it felt relieving. It was not about harm. It was about survival. 4. Blake explains the marks without describing harm. The marks you carry are the physical imprint of a coping behavior that formed under extreme stress. They are not a reflection of who you are today. They are a reflection of what a child endured without support. He speaks with clinical precision, but deep compassion. He continues. And the fact that you grew, healed, sought therapy, pursued education, and built a life, that tells us far more about you than the marks ever could. 5. Blake translates the coded language safely. You communicated your history in a safe, coded way. Those of us trained in trauma-informed care understood exactly what you meant. You did not need to say more. You said enough, and you said it with dignity. 6. Blake addresses the psychological meaning of the veil. As for the veil, many people who have experienced early trauma develop ways of presenting themselves that feel protective. Sometimes it is clothing. Sometimes it is posture. Sometimes it is silence. These are not signs of weakness. They are signs of adaptation. You created a way to move through the world that felt safe. That is resilience. 7. Blake closes with clarity and affirmation. So to answer your questions clinically, you coped the way you did because your young mind was trying to survive something it could not understand. The behavior felt relieving because it created a moment of control in an environment where you had none. The marks are the physical result of a childhood coping pattern, not a reflection of your identity, your worth, or your future. And the fact that you are here today, asking these questions as an adult, tells me that you have already done the hardest part. You survived, and you grew. He steps back, giving the room space to absorb the translation. The room is still absorbing Blake's clinical translation. There's a quiet, collective exhale, the kind that happens when truth has been spoken with care. Tarquin steps forward. 1. Tarquin begins by honoring the courage without centering the trauma. Tarquin speaks. I want to speak to what we just witnessed. Not the details, but the courage. What Rôvi did was something many people never get the chance to do. She named a childhood coping behavior that formed in a moment when she didn't have protection, language, or support. And I want everyone here to understand something very clearly. Coping behaviors that begin in childhood, especially under stress, are far more common than people realize. 2. He normalizes the behavior through community truth. In every community I've worked with, rural, urban, military, working class, immigrant, faith-based, I've seen people carry childhood coping patterns into adulthood. Some scratch, some pick, some shut down, some over-focus, some hide behind clothing or silence. These behaviors don't come from weakness. They come from survival. They come from children trying to make sense of situations they never should have been in. 3. He reframes the marks as history, not identity. And the marks we saw today, those are not signs of shame. They are signs of endurance. They are the physical echo of a child who found a way to keep going when the world around her failed to protect her. He pauses, letting the room absorb the dignity in that statement. Tarquin continues, "Many people in this room carry their own versions of those marks, maybe not on the skin, but in the mind, in the habits, in the ways they move through the world." 4. He protects Rôvi without isolating her. What Rôvi shared is not unusual. It is not rare. It is not something that sets her apart. It is something that connects her to countless others who learned to survive before they learned to speak. And the way she shared it, with restraint, with clarity, with respect for herself and for all of us, that is strength. 5. He brings the room back into unity. So I want everyone here to hear this. If you have ever carried a coping behavior from childhood into adulthood, you are not alone. If you have ever adapted to survive, you are not alone. If you have ever protected yourself in the only way you knew at the time, you are not alone. This seminar is not about exposing anyone. It's about understanding the human ways we cope, and learning healthier paths forward. He steps back, allowing the room to settle into the safety he just created.
After Tarquin finishes, the room is quiet, not tense, but deeply reflective. Amethyst steps forward with her characteristic calm, hands gently clasped, voice soft but steady. Amethyst speaks. "Rôvi, thank you. Thank you for the care you took in sharing your story, and for the strength it took to speak it aloud. You honored yourself, and you honored this room." She gives a small, respectful nod, then she turns to the group. Amethyst continues, "Before we move into our next topic, I want us to take a moment to ground. We've covered something meaningful, and the next section will be emotionally heavy as well. I want everyone to return centered, steady, and supported." She guides the room through a brief grounding exercise, slow breath in, slow breath out, feet on the floor, shoulders relaxed. The room settles. Then she continues, "We're going to take our lunch break now. I know this is earlier than usual, but this is the right moment. Take the time you need. Eat, breathe, reset. For those on parole, please follow escort procedures as usual. If you have forms that need signatures from Dr. Blake or Tarquin, you may bring them forward. At least 2 facilitators or specialists will remain in the room at all times." She gives the room a warm, grounding smile. "You were released for a 1-hour lunch. We'll reconvene afterward." Chairs begin to move immediately. Before Rôvi can even stand, Peggy and Earl are already beside her, parental warmth radiating from both of them. Peggy pulls her into a long, heartfelt hug, tears slipping down her cheeks. She says, "You were one special young lady. You know that." That is all she needs to say. Earl gives Rôvi a gentle, steady look and says, "You're going to be all right, kid." They head to lunch. Rôvi smiled back. Rocky's wife steps forward, sincerity in her eyes. Rocky's wife looks at Rôvi and says, "Thank you for sharing your story. I know adults who never found their footing after what they went through. You did the work. You healed. I'm proud of you." Rôvi smiles softly and replies, "Thank you." At the door, Rocky pauses to hand Tarquin his parole form. Tarquin signs it, calm and professional. Rocky and his wife walk out hand in hand. Charles and Bonnie walk up to Rôvi. Bonnie says, "Thanks for sharing your story. Your strength can help so many." Rôvi smiled, "Thank you." The Marine gave her the universal military to veteran nod. Rôvi nodded back. Charles and Bonnie left for lunch. 3 new parole officers enter to relieve the previous 3. Rich notices immediately, one of them is his own parole officer. They exchange a small nod. Rich gathers his things and heads to lunch, understanding the procedure. He knows he's close to early release. Another parolee in the back waits at the door and is escorted out by security. The room empties. People drift back in slowly, grounded by food and quiet conversation. Rôvi returns with a tray of fruit, salad, and grains. She sits and begins eating. Peggy and Earl return with their trays and sit behind her. Rocky and his wife return and sit at their table, chatting quietly. Rich returns with his tray. He sits, glances at Rôvi, and speaks with quiet sincerity. "Thanks for sharing your story." Rôvi looks up at him with a gentle smile and replies, "Thank you, Rich." They both return to eating. Rocky glances around the room and notices the parole officers have changed, 3 new faces. He knows he's up for early release too. He keeps eating. Blake returns first. He speaks quietly with Tarquin, Amethyst, and the specialists, exchanging observations and notes. Then Tarquin and Amethyst head to lunch. A few specialists step out as well. People continue eating, checking their phones, and talking softly. Rich is on his phone, texting. Suddenly, his parole officer approaches. He bends down to speak quietly to Rich. Peggy and Earl freeze mid-sentences. They can't hear anything. They can only see the posture of the officer leaning in. Peggy whispers, "Earl, what's happening?" Earl keeps his voice calm for Peggy's sake. And calmly replies, "He's up for early release, remember. Probably routine. Maybe a test. Don't worry." Peggy relaxes. But in the back of Earl's mind, the wheels are turning. He replays the moment. Rich was on his phone, typing something. The parole officer walked up at that exact moment. Not just any officer, Rich's parole officer. Rich stopped typing the second the officer approached. Earl doesn't say any of this out loud. He doesn't want to worry Peggy. But privately, he wonders. Was Rich messaging someone he shouldn't? Is this a surprise phone check? Is this about association rules? He keeps all of it to himself. Rocky notices the exchange. So does the Marine, quiet, observant, trained to read body language. After a brief, low conversation, the parole officer straightens and leaves the room. Rich resumes eating as if nothing happened. A moment later, the same parole officer returns with a folder and sits in the back. Earl's stomach tightens. Is that a write-up? Is that a violation report? Oh Lord, please don't let my boy be in trouble. The room settles, unaware of the truth behind the exchange.
The room begins to refill as people return from lunch. Blake steps to the front, tapping his notes lightly. Dr. Blake speaks. "All right, everyone. We'll begin our next and final session in about 5 minutes." A few participants rise to take their trays to the cafeteria cart outside the door. As they return and settle in, Rich comes back to his seat. He straightens his posture, wipes his hands on a napkin, and unlocks his phone. He scrolls through photos, all of them of his daughter. Rôvi, who normally minds her own business, catches a glimpse of the screen. She can't help herself. The little girl's smile is impossible to ignore. Rôvi says, "It looks like your little girl had a birthday party." Rich's face lights up instantly. His whole posture shifts, proud, open, warm. Rich replies, "She did. This was last week. We had her birthday party, and it was perfect. That's actually why I couldn't come to the seminar that day." Rôvi leans in slightly, genuinely interested. Rich notices, and something softens in him. He begins showing her more photos, almost eagerly. Rich says, "And this is her at the animal sanctuary. And this is her at the fair. And this is her favorite dress." Peggy and Earl watch from behind them, smiling like proud relatives. Peggy whispers to Earl, "Look at that, isn't he the most amazing father?" Earl smiles. "He sure is." Rich continues flipping through photos, each one making him sit a little taller. Rôvi studies the images, then looks at him with gentle sincerity. Rôvi says while looking at the photos, "She is so loved. She's the apple of your eye, isn't she?" Rich beams, a quiet, unmistakable pride. Rich smiles and replies back, "She sure is. You know, some guys get disappointed when they find out they're having a daughter. They keep trying for a son. I never understood that." He shakes his head, smiling at the screen. Rich continues, "I'm glad I had a little girl. Especially a little girl with Down syndrome. Her love is pure, unconditional. She never holds anything against me. Even if I'm late picking her up, She just lights up when she sees me. He chuckles softly. Rich continues, and girls don't get into trouble the way boys do. I know how I was as a boy. If I had sons, I'd be chasing them all over the place. But she's sweet, she's gentle, all she wants is time with her dad, even if it's short. Rôvi sees a side of Rich she has never seen before, tender, grounded, deeply human. Peggy and Earl hear every word from behind him. Earl's expression shifts into something new, respect. Blake steps forward again. All right, everyone, we'll now move into our third topic.
The room settles. The last whispers fade. Blake steps forward, the weight of the next topic reflected in his posture. His voice is calm, steady, and unmistakably serious. All right, everyone, thank you for grounding yourselves. We're now moving into our third and final topic of the day, one that is often misunderstood, often minimized, and rarely talked about with the clarity it deserves. He pauses, letting the room lean in. Dr. Blake continues, we're going to talk about facial nerve pain, specifically trigeminal neuralgia. For those who have lived with it, or loved someone who has, you know this is not just face pain. This is a neurological condition that can change a person's entire life. He turns slightly, gesturing toward the specialists seated at the front. Dr. Blake continues, to guide us through this, we have two specialists who bring both clinical expertise and deep compassion. 1. The neurologist. The neurologist steps forward, professional and composed. Dr. Blake continues, first, our neurologist. He's going to walk us through the trigeminal nerve itself, how it works, why it's so sensitive, and what happens when the pain pathways misfire. He'll explain common triggers, why the pain can be so severe, and most importantly, why this condition is not psychological. A few people in the room shift, listening more closely. Dr. Blake continues, he'll help us understand the biology behind the experience, so we can remove stigma and replace it with knowledge. The neurologist gives a small, respectful nod and sits. 2. The pain management specialist. Blake gestures to the second specialist. He continues, next, our pain management specialist. He'll focus on what life looks like for someone living with trigeminal nerve pain, the coping strategies, the lifestyle adjustments, and the day-to-day realities. He'll also speak directly to families and loved ones. Because support matters, understanding matters, and knowing how to help, without overwhelming, can make all the difference. Blake steps back to the center. He continues, this is a heavy topic. It affects identity, relationships, work, and daily functioning. But you are safe here. You are supported, and you are not alone. He gives a small nod to the neurologist. Dr. Blake continues, let's begin. The room quiets completely. The neurologist rises. The third topic begins.
Dr. Mercer steps forward. Dr. Mercer, hello. My name is Dr. Mercer, and I'm a neurologist. My work focuses on the nervous system, specifically, how pain signals travel from the body to the brain, and what happens when those signals become disrupted. She clicks the remote. A clean anatomical diagram of the trigeminal nerve appears on the screen behind her. She continues, I want to begin with the trigeminal nerve. It is the largest sensory nerve in the face, and it has 3 major branches, one to the forehead, one to the cheek, and one to the jaw. Every sensation you feel in your face travels through these branches. She gestures gently to the diagram. She continues, when this nerve becomes irritated, compressed, or damaged, the pain can be severe. Not mild, not uncomfortable, severe. It can feel electric, stabbing, burning, or sudden, and it can come without warning. The room is silent, listening. She continues, I want to address something directly, because many people in this room may have heard the opposite. Trigeminal neuralgia is not psychological. It is not imagined. It is not exaggerated. It is not caused by stress or emotion. She lets that settle, her tone firm but compassionate. She continues, When the trigeminal nerve misfires, the brain receives pain signals that are real, intense, and overwhelming. These signals travel along pathways that have nothing to do with personality, mood, or mental state. They are biological. She clicks to the next slide, a close-up of the nerve root. She continues. Triggers vary from person to person. For some, it's a light breeze. For others, brushing their teeth, eating, talking, smiling. Even the vibration of footsteps in the room can set it off. A few participants shift in their seats, recognizing themselves or someone they love. She continues. And because the pain can be unpredictable, people often change how they move, how they speak, how they eat, and how they interact with others. Not because they want to withdraw, but because their nervous system is trying to protect them. My role today is to give you clarity, to help you understand the biology behind this condition, to give you language for what you or someone you love may be experiencing, and to remove the stigma that has followed this condition for far too long. After I walk you through the nerve pathways and the mechanisms of pain, our pain management specialist will talk about what life looks like for someone living with this condition, and how families can support them without overwhelming them. Let's begin. The room leans in. The teaching segment starts.
Dr. Mercer clicks to the next slide, a detailed illustration of the trigeminal nerve branching across the face. Her voice remains steady, but there is a quiet intensity behind it. She is a woman who has explained this hundreds of times, yet never casually. 1. The structure of the trigeminal nerve. Dr. Mercer speaks. The trigeminal nerve is the fifth cranial nerve, and it is responsible for most of the sensation in your face. It has 3 major branches. She points to each one. She continues. The ophthalmic branch, the forehead and eye region. The maxillary branch, the cheek and upper jaw. The mandibular branch, the lower jaw. She pauses. She continues. When people say, "My whole face hurts," they're often describing pain that follows one or more of these branches. And because these branches are so sensitive, even a small irritation can create a very large response. 2. How pain signals travel. She clicks again. A diagram of the brainstem appears. She continues. Pain signals from the face travel through the trigeminal nerve into the brainstem, specifically the trigeminal nucleus. From there, they move to the thalamus, the brain's relay center, and then to the cortex, where the sensation becomes conscious. When this pathway is functioning normally, it helps you detect danger, heat, cold, pressure. But when the nerve is damaged or compressed, the pathway becomes distorted. She taps the diagram lightly. She continues. Instead of sending accurate information, the nerve sends bursts of pain signals that do not match what is happening in the environment. 3. What causes the misfiring? She clicks to a slide showing a blood vessel touching the nerve root. She continues. One of the most common causes is vascular compression, a blood vessel pressing against the nerve where it enters the brainstem. Over time, that pressure can wear away the protective coating around the nerve, making it hypersensitive. She continues. Other causes include inflammation, trauma, dental procedures, sinus issues, or neurological conditions that affect the myelin, the insulation around the nerve. And sometimes, we never find the exact cause. But the pain is still real. The pathways are still disrupted. 4. Why the pain is so intense. She clicks again, a slide showing the nerve firing repeatedly. She continues. The trigeminal nerve is one of the most densely packed sensory nerves in the body. When it misfires, it doesn't send a gentle signal. It sends a surge. She holds up her hand, mimicking a sharp burst. She continues. That's why people describe the pain as electric, stabbing, or lightning-like. It's not a dull ache. It's a sudden, overwhelming shock that can stop someone mid-sentence. She lets the room absorb that. 5. Common triggers. She continues. Triggers vary widely. For some, it's brushing their teeth. For others, chewing, talking, smiling, a cold breeze, washing their face, even the vibration of footsteps in the room. These triggers are not psychological. They are mechanical. The nerve is responding to movement, temperature, or touch, not emotion. 6. Why it's not psychological. She clicks to a slide showing the nerve root under a microscope. She continues. I want to emphasize this again. Trigeminal neuralgia is not caused by stress, anxiety, or emotional distress. People with this condition are often told they're exaggerating, or that the pain is, in their head. That is incorrect. The pain originates in the nerve root, not in the mind. She pauses, letting the weight of that truth settle. She continues. Stress can make any medical condition harder to manage, but it does not cause this one. The biology is clear. 7. The impact on daily life. She clicks to a final slide, a simple outline of a human face. She continues. When pain is unpredictable, people begin to move differently. They may avoid talking, smiling, eating certain foods, or going outside on windy days. They may appear withdrawn, but they are not avoiding people, they are avoiding pain. This condition affects identity, relationships, work, and daily functioning. It requires understanding, patience, and support. Now that we've covered the biology, our pain management specialist will talk about what life looks like for someone living with this condition, and how families can support them without overwhelming them. She gives a small, respectful nod. She adds, "Thank you." She returns to her seat. The room is silent, absorbing every word.
The pain management specialist rises slowly, adjusting his tie with a quiet, practiced motion. He steps to the front of the room, not with intensity, but with a steady presence, the kind of presence that tells the room he has sat with many people in pain, and he takes that responsibility seriously. He speaks. Thank you, Dr. Mercer. And thank you all for staying present with this topic. My name is Dr. Adrian Cole, and my work focuses on helping people live with chronic pain, not just medically, but practically, emotionally, and relationally. He glances around the room, making gentle eye contact. He continues, now that you understand the biology of trigeminal nerve pain, I want to talk about what it feels like to live with it. Not the science, the experience. He pauses, letting the room settle into the shift. He continues, facial nerve pain changes daily life in ways most people never think about. It affects eating, speaking, brushing your teeth, washing your face, going outside on a windy day, even laughing. Things that should be simple become calculated. He continues, my role today is to walk you through 3 things. First, coping strategies that actually help. Second, lifestyle adjustments that reduce flare-ups. And third, how families and loved ones can support someone without overwhelming them. He continues, because support is not just about being present. It's about understanding what helps, what hurts, and what a person needs in the moment. I want to start by saying this: people with trigeminal neuralgia are not weak. They are not dramatic. They are not avoiding life. They are managing a condition that can be unpredictable, frightening, and physically exhausting. He lets the truth land. He continues, and the people who love them often feel helpless, not because they don't care, but because they don't know what to do. That's what we're going to talk about today. So let's begin with coping strategies, the tools people use to get through the worst moments, and the small adjustments that can make daily life more manageable. The room leans in. The emotional weight deepens. The teaching continues.
Dr. Cole steps a little closer to the audience, his posture relaxed but attentive. He speaks with the steady cadence of someone who has walked many people through the worst days of their pain. He continues, when someone is living with trigeminal nerve pain, the goal is not to push through or tough it out. The goal is to work with the nervous system, not against it. So let's talk about coping strategies, the ones that actually help. Not quick fixes, not myths, not things people say because they don't know what else to offer. I'm talking about tools that reduce the intensity of flare-ups and help people regain a sense of control. He pauses, letting the room settle. 1. Predictability and routine. He continues, One of the most effective strategies is creating predictability. The trigeminal nerve reacts strongly to sudden changes, temperature shifts, unexpected touch, abrupt movement. So building a routine helps stabilize the nervous system. He lists them calmly, without rushing. He continues, consistent sleep, consistent meals, consistent hydration, consistent medication timing, consistent morning and evening rituals. When the body knows what to expect, the nerve is less likely to misfire. 2. Gentle movement instead of bracing. He continues, many people instinctively tense their jaw or hold their breath when they feel pain coming. That's a natural reaction, but it can actually make the pain worse. Instead of bracing, we teach gentle movement. Slow jaw relaxation, soft neck stretches, controlled breathing. These techniques calm the brainstem and reduce the intensity of the pain signals. 3. Temperature awareness. He continues, temperature is one of the biggest triggers. Cold air, hot drinks, even a draft from a doorway can set off the nerve. So we teach people to carry a scarf, avoid sudden temperature changes, and let food cool before eating. These small adjustments prevent a lot of unnecessary pain. 4. Sensory shielding. Some people benefit from what we call sensory shielding, reducing stimulation to the affected side of the face. That might mean using a soft mask in the winter, avoiding wind exposure, or using a warm compress during early warning signs. It's not about hiding, it's about protecting the nerve. 5. Early warning signals. Most people with trigeminal neuralgia eventually learn the early signs of a flare, a tingling, a pressure, a subtle shift in sensation. When you catch those early signals, you can intervene before the pain peaks. That might mean pausing a conversation, stepping indoors, taking medication, or grounding the nervous system with slow breathing. 6. Reducing overload. Stress doesn't cause trigeminal neuralgia, but it can amplify it. Not because the pain is psychological, but because the nervous system becomes more reactive when it's overwhelmed. So we teach people to reduce overload. Shorter conversations, quieter environments, less multitasking, more breaks. He adds, this isn't weakness, it's strategy. 7. Support without pressure. He shifts slightly, addressing the families in the room. He continues, and for loved ones, one of the most powerful coping tools is support that doesn't pressure. Not asking someone to talk through the pain. Not insisting they try harder. Not pushing them to eat or speak when it hurts. Instead, offer presence, offer patience, offer options, let them set the pace. 8. Reclaiming small joys. He continues, pain can shrink a person's world. So part of coping is finding small, safe joys, music, warm blankets, gentle routines, quiet hobbies, time with people who don't demand anything. These moments don't cure the pain, but they restore the person. Closing the coping section, he continues, these strategies don't eliminate trigeminal neuralgia, but they help people live with it, with dignity, with agency, and with fewer flare-ups. He continues, next, we'll talk about lifestyle adjustments, the long-term changes that make daily life more manageable. The room stays quiet, absorbing every word.
Dr. Cole steps forward again, this time with a gentler posture. He isn't speaking as a clinician now. He's speaking as someone who has sat with families in waiting rooms, living rooms, and hospital rooms. His voice is steady, warm, and deeply human. 1. Support without pressure. One of the most important things families can offer is support that doesn't pressure. When someone is in pain, especially facial nerve pain, they cannot always talk, eat, or respond the way they normally would. So instead of asking them to explain what's wrong, or encouraging them to push through, simply offer presence. Sit with them. Let them set the pace. Let them decide when they're ready to speak or move. 2. Don't take withdrawal personally. When the pain flares, people often become quiet. They may turn their head away, avoid conversation, or step into another room. He shakes his head gently. This is not rejection, it's protection. They're trying to prevent the pain from getting worse. Families who understand this create safety instead of tension. 3. Ask what helps. Don't assume. Everyone's triggers are different. For one person, cold air is the enemy. For another, it's chewing. For another, it's talking. So instead of guessing, ask simple, respectful questions. Would you like quiet? Do you want me close or would you prefer space? Is this a good time to talk or should we wait? Let them be the expert on their own body. 4. Protect the environment. Dr. Cole, families can make small adjustments that have a big impact. Closing a drafty window, lowering the volume, avoiding sudden temperature changes, keeping conversations gentle and unhurried. Cole, these are small acts of care that prevent unnecessary pain. 5. Avoid minimizing or spiritualizing the pain. Comments like, "It can't be that bad, just relax," or, "Maybe it's stress," are deeply harmful. So are statements like, "You just need to think positive," or, "You need more faith." This pain is neurological. It is real. Families who acknowledge that create trust. 6. Celebrate the good days without expecting them to last. People with trigeminal neuralgia often have unpredictable cycles. Good days, bad days, and days that change hour by hour. He continues, "When a good day comes, enjoy it. Celebrate it. But don't assume it means the pain is gone. And don't express disappointment when the next day is harder. Consistency in your emotional response helps them feel safe." 7. Learn the early warning signs. Many people can sense a flare coming, a tingling, a pressure, a shift in sensation. When families learn these signs, they can adjust the environment quickly. Lower the noise. Pause the conversation. Offer a scarf or warm compress. These small actions prevent escalation. 8. Respect their limits, even when you don't understand them. If they say they can't talk right now, believe them. If they say they can't eat that food, believe them. If they say they need quiet, believe them. He pauses, letting the room absorb the weight of that. You don't have to understand the pain to respect the boundary. 9. Stay connected in ways that don't require speech. Facial nerve pain can make talking difficult. But connection doesn't have to disappear. He offers gentle examples. He continues, "Sit beside them. Send a text instead of asking a question out loud. Offer a warm drink. Put on a familiar show. Share space without demanding interaction. Love doesn't always need words." 10. Be patient with the emotional toll. Chronic pain affects mood, energy, and identity. People may grieve the life they used to have. Families who allow space for that grief, without trying to fix it, become a source of strength. He concludes gently, "Your steadiness matters more than you know." Closing the family guidance section. When families understand the condition, respect boundaries, and offer support without pressure, the person in pain feels safer, calmer, and less alone. And that emotional safety reduces flare-ups more than most people realize. Next, we'll talk about lifestyle adjustments, the long-term changes that help people live with this condition day to day. The room remains silent, absorbing every word.
Dr. Cole takes a slow breath, giving the room a moment to settle after the coping strategies segment. He steps slightly to the side, adopting a posture that is less formal and more conversational, the stance of someone who has walked alongside many patients for years. His voice is warm, steady, and deeply practical. 1. Build a life that doesn't provoke the nerve. Lifestyle adjustments are not about restriction. They're about designing a life that doesn't constantly provoke the trigeminal nerve. He gestures gently with an open hand. He continues, "That means identifying patterns, what makes the pain worse, what makes it better, and what keeps it stable. Once you understand those patterns, you can build your routines around them." Temperature management. Temperature is one of the biggest triggers. So one of the first adjustments we recommend is temperature management. He lists them calmly. He continues, "Scarves in cold weather. Avoiding direct air from fans or vents. letting food cool before eating, using lukewarm water instead of hot or cold. He adds, these small changes prevent a surprising number of flare-ups. 3. Gentle eating habits. Eating can be one of the hardest daily tasks for people with trigeminal neuralgia. So we adjust the approach. He explains, softer foods on bad days, chewing on the unaffected side, avoiding crunchy or sticky foods, taking smaller bites, eating slowly. This isn't about limiting joy. It's about reducing strain. 4. Speech and social adjustments. Talking can trigger pain for some people. That doesn't mean they don't want connection, it means they need connection that doesn't require constant speech. He offers examples: shorter conversations, texting instead of calling, quiet companionship, letting others carry the conversation when needed. These adjustments protect the nerve while preserving relationships. 5. Environmental control. People with trigeminal neuralgia often do best in environments that are calm, predictable, and low stimulation. He lists them clearly: soft lighting, minimal drafts, reduced background noise, avoiding sudden temperature shifts, choosing seating away from doors or windows. He adds, these aren't luxuries, they're necessities. 6. Energy conservation. Chronic pain drains energy, not because the person is weak, but because the nervous system is constantly working overtime. He continues, Dr. Cole, so we teach pacing, breaking tasks into smaller steps, taking rest breaks before exhaustion hits, scheduling demanding activities for times of day when symptoms are usually calmer. He pauses. Dr. Cole, this protects both the body and the mind. 7. Medication timing and consistency. Medication works best when taken consistently, not reactively. He explains, set alarms, use pill organizers, keep a small supply in your bag or car. Never skip doses on good days. Consistency stabilizes the nerve, inconsistency destabilizes it. 8. Reducing overload and sensory stress. Overstimulation, noise, crowds, bright lights, multitasking can make the nervous system more reactive. He offers alternatives: quiet spaces, simplified routines, one task at a time, shorter outings, more recovery time afterward. He adds, this isn't avoidance, it's strategy. 9. Emotional boundaries. His tone becomes protective. He continues, people with chronic pain often feel pressure to reassure others, explain themselves, or pretend they're okay. That emotional labor makes the pain worse. So one of the most important lifestyle adjustments is learning to set boundaries. He offers examples: not right now, I need quiet, I can't talk at the moment, I need to rest. These boundaries are not selfish. They're essential. 10. Rebuilding identity and joy. Chronic pain can shrink a person's world. So part of lifestyle adjustment is rebuilding joy, slowly, intentionally, and without pressure. He offers gentle suggestions: quiet hobbies, warm blankets, music, nature, time with people who don't demand anything. These moments don't cure the pain, but they restore the person. Closing the lifestyle adjustments section. Lifestyle adjustments are not about giving up the life you want. They're about creating a life that doesn't constantly provoke the nerve, a life that is calmer, safer, and more predictable. Next, we'll talk about how families can support someone living with this condition without overwhelming them. The room remains silent, absorbing every word.
Here is Dr. Blake's clinical. Blake steps forward again, giving both specialists a respectful nod before turning back to the room. His posture is steady. His voice is low, warm, and unmistakably clinical. Dr. Blake speaks. Thank you, Dr. Mercer. Thank you, Dr. Cole. He lets a quiet moment settle, the kind of pause that signals a shift from medical explanation to psychological integration. He continues, I want to take a moment to talk about the psychological impact of trigeminal nerve pain, not the cause, but the consequences. Because as both of our specialists made clear, This condition is neurological. It begins in the nerve. But it does not end there. 1. The nervous system and identity. When pain is unpredictable, the nervous system stays on alert. People begin to anticipate pain even when it isn't present. That anticipation is not anxiety, it is conditioning. It is the brain trying to protect the body. And over time, that constant vigilance can change how a person sees themselves. They may feel fragile, unreliable, or burdensome, not because they are, but because the pain interrupts their ability to show up the way they want to. 2. The emotional toll of unpredictability. One of the hardest parts of this condition is the unpredictability. You can be fine at 10 a.m. and unable to speak at 10:03. That kind of instability affects confidence. It affects relationships. It affects a person's sense of control. And when people feel out of control, they often withdraw, not from others, but from the fear of disappointing others. 3. The impact of being misunderstood. Many people with trigeminal neuralgia have been dismissed, minimized, or told their pain is emotional. That kind of invalidation leaves a mark. It creates shame where there should be none. So part of healing is not just managing the pain, it's repairing the damage caused by years of being misunderstood. 4. The role of loved ones. When families understand the condition, the person in pain feels safer. When families misunderstand it, the person feels alone, even in a full room. Support is not about fixing the pain. It's about reducing the emotional load that comes with it. 5. Restoring agency. One of my goals, clinically, is to help people reclaim agency. Chronic pain can make life feel small. But agency returns when people learn their patterns, understand their triggers, and build routines that protect their nervous system. That's why the strategies you just heard are so important. They're not restrictions. They're tools. They give people back a sense of control. 6. The psychological strength of people living with this condition. I want to say something clearly. People living with trigeminal neuralgia are not weak. They are not fragile. They are not dramatic. They are resilient in ways most people will never understand. He lets the truth settle. He continues. Living with unpredictable pain requires courage. It requires discipline. It requires emotional strength. And it deserves recognition. 7. Closing the clinical perspective. So as we move into the next part of our session, I want you to hold on to 3 things. You are not imagining this. You are not alone in this. And you are not defined by this. Let's continue. The room is silent, not heavy, but understood.
The room is quiet after Blake's clinical perspective, not heavy, but thoughtful. People sit a little straighter. A few fold their hands. A few look down at their notes. It's the kind of silence that means the room is ready. Blake steps forward again, softening his posture. He is no longer in teaching mode. He is in holding the room mode. His voice is warm, steady, and unmistakably gentle. Blake begins. Thank you for staying with us through all of that. I know this topic is dense. I know it's personal for some of you. And I know it can bring up memories, questions, and emotions that don't always have a place to land. He lets that breathe. He continues. So before we move on, I want to open the floor, not for pressure, not for performance, but for connection. He glances around the room, making eye contact without singling anyone out. He continues. If you've lived with this condition, if you've supported someone who has, if you've been dismissed, misunderstood, or told it was in your head, and you feel comfortable sharing, even just a sentence, this is a safe place to do that. He raises a hand slightly, signaling the boundaries. He continues. You are not required to speak. You are not expected to speak. Silence is participation. Listening is participation. Breathing is participation. We'll take a few voices. Whoever feels ready. And if no one speaks, that's perfectly fine. The goal here is not to fill the air. The goal is to make room for whatever needs to be heard. The floor is open. The room stays quiet for a moment. The kind of quiet that feels like a held breath. Then a chair shifts softly. Someone inhales. A hand rises. The sharing begins.
Blake steps back, giving the room space. A hand rises near the middle row. A man in his late 20s stands slowly. Blake gives him a small nod of permission. Hi. My name is Daniel. I'll keep this short. I've got trigeminal neuralgia, and I ended up losing my job because of it. I was working fast food. Drive-through, grill, everything fast, everything loud. And every time the pain hit, I had to step away. Sometimes it was a cold draft from the freezer door. Sometimes it was talking too much. Sometimes it was just nothing. It just hit. I kept asking to be excused. I wasn't trying to slack off. I just needed a minute to breathe. My boss got tired of it. One day he pulled me aside and said he couldn't keep someone who disappeared every hour. And that was it. Fired. That's what I'm dealing with. He sits. Another hand rises. A man in his mid-30s. Blake gives him the nod. He stands, rubbing the back of his neck. My name's Jared, and for me, it's relationships. I was with someone for a while, and she couldn't handle it. I didn't tell her what I had. I didn't want her thinking I was weak or disabled. So I just said I had migraines. Or a toothache. Or I was tired. But the truth is, the pain made me short-tempered. Quiet. Sometimes I'd pull away because talking hurt. She thought I was losing interest. She thought I didn't care. She left. And since then, dating has been hard. I'm embarrassed to explain it. I don't want to scare anyone off. But hiding it hasn't worked either. So I'm stuck. He sits. A woman in her 60s raises her hand. Blake nods gently. She stands, holding the back of her chair for balance. My name is Marilyn, and my struggle is with my family. My children, my grandchildren. They want to spend time with me. They want to hug me, climb on me, talk a mile a minute. But their energy, their hyperness, it triggers my symptoms. My husband has been wonderful. He steps in. He helps. But it's changed my relationship with my grandkids. They think I'm cranky. They think I don't want to play. And I don't know how to explain to a 5-year-old why grandma can't handle loud noises or sudden movements. That's my reality. She sits. The room is silent. Not heavy, but deeply attentive. Dr. Cole rises, hands clasped gently in front of him. Dr. Cole speaks. Thank you, all three of you, for sharing that. What you described is real. It's common. And it deserves to be understood. He turns slightly toward Daniel and say, Daniel, losing a job because of unpredictable pain is not a failure on your part. Fast-paced environments, temperature shifts, constant talking. These are some of the strongest triggers for trigeminal neuralgia. You weren't unreliable. The environment was incompatible with your condition. And there are workplaces that can accommodate you once you have the language to explain what you need. He shifts toward Jared and say, Jared, hiding the condition is incredibly common. People fear being judged, misunderstood, or seen as weak. But secrecy creates confusion in relationships. When partners don't know the truth, they fill in the blanks with their own interpretations. Honesty won't guarantee a perfect relationship, but it will give the right person a chance to understand you instead of guessing. He turns to Marilyn and say, and Marilyn, your story is one I hear often. Children don't understand pain they can't see. They interpret withdrawal as rejection. But with gentle explanation, age-appropriate language, and support from your husband, you can rebuild connection in ways that don't overwhelm your nervous system. He looks at all three and says, "None of you are failing. You are adapting to a condition that demands adaptation. And the more people understand the triggers, the biology, and the emotional toll, the less alone you will feel." He sits. Taquan steps forward. "I want to add something from the community side. What all three of you described has one thing in common: misunderstanding. People don't know what they're looking at. They see behavior, not the condition behind it. So part of healing is education. Not just for you, but for the people around you. When folks understand what trigeminal neuralgia actually is, they stop taking things personally. They stop assuming the worst. And they start supporting you the right way. You're not alone in any of this." He sits.
Blake steps forward again. "Thank you, all three of you. What you shared today wasn't just personal, it was educational. You gave this room something that no slide, no diagram, no lecture could ever provide: the lived reality. Daniel, Jared, Marilyn, your stories show the full spectrum of what this condition can take from a person. Work, relationships, family connection, identity. And you spoke with honesty, not self-pity. That matters. I want everyone in this room to hear something clearly. None of what they described as a character flaw. None of it is weakness. None of it is failure." He lets that settle. Dr. Blake continues, "When a condition affects your ability to speak, eat, smile, or be touched, it affects every part of your life. And the world is not built with this condition in mind. Workplaces aren't built for it. Dating culture isn't built for it. Even family routines aren't built for it. So when someone with trigeminal neuralgia loses a job, or a relationship, or a sense of closeness with their children, it is not because they didn't try hard enough. It is because the environment didn't understand what they were carrying. And that is why we teach. That is why we bring specialists. That is why we create rooms like this, rooms where the biology, the psychology, and the lived experience can finally be seen together. For those of you who shared, you did not just speak for yourselves. You spoke for every person who has been dismissed, misunderstood, or told to push through something that cannot be pushed through. And for those of you listening, let their stories change the way you see this condition. Let them change the way you respond to the people in your life who live with invisible pain. The segment closes with dignity. Blake steps forward again, hands resting lightly on the podium. The room has settled after the participant stories and the specialist responses. He scans the faces, calm, steady, making sure no one is left behind. Dr. Blake continues, "Before we wrap up, I want to open the floor one last time. If anyone has any questions, even if they're not related to today's topic, you're welcome to ask." He waits. He scans the room slowly, giving everyone a chance. But the room is quiet. People look content, grounded, satisfied. Blake gives a small nod. Dr. Blake continues, "All right then. I want to thank every one of you who participated today. And for those who didn't, don't worry. We'll have a part 2 in the future, and you'll have your opportunity to speak if you choose to." He gestures toward the front table. Dr. Blake continues, "For those of you on parole, if you need any forms signed, either I or Taquan will be glad to take care of that for you before you leave." Taquan is already stepping forward, clipboard in hand. Dr. Blake continues, "And before you go, I want to let you know about our next seminar. We'll be focusing on driver's education, specifically the written test. A few heads lift with interest. Dr. Blake, most people can physically drive. Even toddlers can steer their little toy cars. But the written test, that's where people struggle. Not because they're incapable, but because written tests are designed for one type of learner. One wiring, one style. And the truth is, there are 5 or 6 other ways people learn. He pauses, letting the room absorb that. Dr. Blake continues, that's why so many fail the written test. Not because they can't drive, but because the test wasn't built for their brain. So if you'd like to sign up for that seminar, the clipboard is right here. Taquan places the clipboard on the front desk with a soft tap. Dr. Blake continues, thank you again for your honesty, your presence, and your courage today. Stay safe, stay grounded, and have a beautiful rest of your afternoon. He steps back. The room exhales. Chairs slide. Backpacks zip. People gather their things. Bubba and Ruby Joe make a beeline for Peggy and Earl, talking a mile a minute, laughing, catching up like family does. Rocky stands, slings his backpack over one shoulder, and reaches for his wife's hand. He notices the 3 parole officers heading out the door, all satisfied, all nodding to one another. Rocky relaxes. He and his wife walk to the front and sign up for the driver's ed seminar. Then Rocky pulls a folded form from his back pocket. Rocky asks, excuse me, Taquan, can you sign this for me? Taquan signs it without hesitation. Rocky gives his wife a gentle squeeze, glances over at Rich, and gives him the classic upper chin nod. Rich returns it with a small smile. Rocky and his wife walk out arm in arm. A few participants line up to sign the clipboard. Specialists begin packing their materials. Peggy and Ruby Joe are still chatting, animated, warm, unstoppable. Bonnie and Charles the Marine walk over to join Bubba and Ruby Joe, forming a small family circle. Rôvi steps forward and signs up for the driver's ed seminar. Rich signs up as well. Earl spots Rich and moves quickly, pulling him aside with gentle urgency. Earl says, hey, son, listen, you know I love you like my own. I just want to make sure everything's all right. I saw your parole officer come over earlier, and you were texting right before that. I ain't trying to get in your business or nothing, I just wanna to make sure you're okay. Rich smiles, warm, appreciative, and responds. I appreciate that, sir. Really. But everything's fine. I was texting my PO to request a travel pass. He wasn't here for me, he's got another client in this group. I just used the chance to ask him. Earl nods, listening closely. Rich adds, the mother of my daughter had to change the visitation date. If I didn't request the pass today, I'd miss it. My PO came over to tell me he'll put the request in right away. Earl exhales, a long, relieved breath and responds. Oh, I'm so glad to hear that. You nearly gave me a heart attack. Rich chuckles softly and replies. Thank you, I appreciate you checking on me. He finishes signing up for the driver's ed seminar. Earl walks over to Bubba and Ruby Joe, excited and says. Hey, I want y'all to meet someone. You know that young man Rich I've been telling you about. Bubba grins. Bubba, oh, felony. Earl waves him off. Earl, he don't go by that name no more. Come on, let me introduce you. Earl turns. Rich is gone. Just like that. Earl chuckles. Well, maybe next time. People finish signing up. The specialists finish packing. The last conversations fade. The classroom lights dim slightly as the day winds down. The next seminar, driver's education, the written test, is already waiting in the wings. And that is how the session ends.